Can you hear me?
Yes, Mr. Mwase, you're loud and clear.
Okay, can you see the slide I put on there?
Yes, we can see.
Okay, so this presentation is about patient with suspicion of acute appendicitis presenting for ultrasound. I decided to choose this topic because there are so many ways of how appendicitis is identified in terms of radiology. So we have the ultrasound, we have the CT, we have the MRI, but I decided to only to choose for ultrasound because ultrasound is locally available and it's cheap, and it's a thing that we take for granted that sometimes patient comes for ultrasound, say, oh no, don't do ultrasound, just go for CT, it's easy. So in terms of that, I decided, okay, maybe I choose this topic because everyone is aware about how to do ultrasound for appendicitis, but practically sometimes we don't do it the right way. So that's why I decided to come up with this topic. So the presentation overview, we're going to talk about the introduction and the anatomy, pathophysiology of acute appendicitis, ultrasound scanning tips, ultrasound features of normal appendix, as well as acute appendicitis. And then lastly, we're going to look at auditing ideas. Appendicitis constitutes one of the most common abdominal images with a lifetime prevalence of about 7%. The diagnosis of acute appendicitis is a clinical diagnosis based on the findings from the patient's history and physical examination. One of the criteria for diagnosis based on the clinical signs and examination is Appendix standard, which includes signs and symptoms of abdominal pain and migration, nausea, anorexia, rebound tenderness, and fever, and as well as laboratory criteria of leukocytosis and shift of left of neutrophils. So the patient present to ED, the doctor asks what's the problem, and he explained about the symptoms and the signs and symptoms, and then the doctor does some laboratory test and then decided, oh, this patient might or might not be appendicitis. So they use Appendix standard to either have a picture that this patient might have appendicitis, or this patient maybe the problem with this patient is nothing to do with appendicitis. So how does this Appendix standard work about? So the total value for the score is 10. So each has got a value of 1, except only 2 things, the sign, the right lower quadrant tenderness, which has got a 2. And the laboratory results of leukocytosis got 2, and the rest have got 1, 1. So according to how the patient presents, has a patient light lower quadrant tenderness, 2. As the patient elevated temperature, that's you add 1. Or what about the blood results? You add 2 or 1. What about is the patient vomiting, has nausea? So when the doctor is looking at those values, then he's able to make a choice whether there's real appendicitis or no appendicitis, or you need some further investigation. So if a patient has a score of 7 to 10, there's a strongly predictive of appendicitis. So in that case, they know that this typical appendicitis, they may just take the patient to theater, take the appendix out. If the patient has a score of 5 to 6, that's where they need radiological investigation. So the radiological investigation can be either ultrasound, CT, or MRI. In this case, I will concentrate with ultrasound. And if a patient has got a score of 1 to 4, that means appendicitis is ruled out. So they rule out appendicitis and they look for other things which may cause patient pain. So let us just look at the appendix. Appendix is a bright-ended tube at the end of the cecum. So average length is 10 centimeters and measures between 3 to 6 millimeter in diameter. So the location is variable. So as you can see from this diagram here, you see that the appendix can be anywhere coming from the base of the cecum. And sometimes the majority of it, you can see here, retrocecal, 65%, that the appendix point behind the colon. And then some majority, they go into the pelvis. So when we are looking that, we know that the appendix is coming from this base, but where exactly is it pointing at? So it is our job when doing the ultrasound scan to evaluate the whole appendicitis size, the appendix size, to see where it is, whether it's normal or not. McBurney's point. McBurney's point is the name given to the point over the right side of the abdomen. That is approximately 1/3 of the way between the umbilicus and the anterior superior iliac spine. So this point is roughly the location of the base of the appendix where it is attached to the cecum. So we know where the base is, where the base of where appendix is coming from, but we are not sure where exactly is it going at. So in this case, the appendix can point into any of this area here, the blue area here, okay? We know the base, but it can be anywhere pointing out. And let us look at the layers of the appendix. So this is a diagram of the appendix, and this is the ultrasound image of the appendix. So you have got the lumen inside, this collapse here, and then you have got the mucosa, submucosa, the muscular wall, and the serosal outside. The same here showing up here. So those are the layers of the appendix. You take that appendix, you cut inside, you are looking at the layers of it. If you look at the diagram of the normal appendix, this one, that's the normal appendix, the top one, okay, how it should be like. But when it is inflamed, it looks like this. So, and most of the time, patients complain of pain around the right lower quadrant. So we're going to see what makes the appendix to change from this, the way it's looking here, to the way it's inflamed here. Causes of acute appendicitis. So appendicitis results from obstruction from the lumen of the appendix. So the first image, so this is the lumen here inside the appendix there. So if there's an obstruction there, following obstruction, there's an increase in the production of mucus, which leads to an increase in the pressure as well as overgrowth of bacteria. This leads to distension of the appendix, and the visceral pain is usually located in the epigastric or periumbilical area. As the luminal pressure increases, obstruction of the lymphatic system occurs, causing edema of the appendix. So this stage is called acute appendicitis. So the pain becomes localized to the right lower quadrant. As you can see here, putting the arms, the hands where the pain is. Imaging. Ultrasound is the first imaging modality of choice in patients with suspected appendicitis due to its accessibility, lack of ionizing radiation, and good diagnostic accuracy reported in the literature. Every hospital has an ultrasound scan. Every hospital doesn't have a CT scan or doesn't have an MRI scan. So the ultrasound is easily accessible to any patient. There's no concern about radiation because there's no radiation involved. So that's a good thing of ultrasound. However, various challenges of ultrasound in its diagnostic performance depends on the operator's experience, patient population characteristics, either between pediatrics versus adult, and the body mass index of an individual. So these things makes ultrasound to be difficult because it all depends on the experience of who is doing the scan. The patient type, how big is the patient, how small is the patient. All those things determine you where you're able to visualize the appendix or not. Using ultrasound, use high resolution linear probe, and the normal appendix can be visualized from the base of the cecum. And the thickness is 2 millimeters and the diameter is 6 millimeters. For larger patient, you should have a lower frequency probe. So generally, when you're doing the scan, make sure that your scanner has at least 2 transducer, the probes, the high resolution linear probe and the low frequency probe. Steps. Graded compression of the right lower quadrant remain the mainstream of ultrasound technique for the evaluation of appendicitis. So this decreases the distance between ultrasound probe and the appendix, as well as displacing the bile gas. The goal of ultrasound is not only to find appendicitis, but also the normal appendix. We should have, because you should have adequate time to perform the study. You can't look for appendix in a hurry. This is another sound image showing appendix. So you can see this joining from the cecum here. This one is appendix here with a distance of 3 millimeters. And you can see the source muscle and the terminal ilium, as well as the rectus muscle. So it's coming, as we have said, appendix comes from the cecum, base of the cecum, but where it points, it varies. So you have the patient in the clinician send you a patient for ultrasound. They're looking whether to see if the patient has got appendicitis or not. The first thing, you have the patient in your room, you ask the patient, can you point with one finger where the pain is? And the patient should point with one finger where they feels most pain. So you start with graded compression over the area of the maximum tenderness are determined by the patient. So the patient tells you, I feel more pain here. So you have to put your probe direct there and check both in transverse and longitudinal. If the appendix is not identified in that location, a careful systematic approach should be followed. How do you do that? You begin from the hepatic pressure and slowly moving down toward the cecum. You make sure that the whole right lower quadrant is evaluated. So you go through, you try to look around all the areas to make sure that the whole area is fully evaluated. Hence, the iliac vessel and source muscle can be used as important landmarks, as most appendices are anterior to these structures. So these are the 2 iliac vessels and the source muscles here, and the appendix is anterior. So most of the cases, if you can't find where appendix is, try to find where the source muscle is and where the iliac vessels are, and try to look anterior to those 2 structures. Another thing is placing the patient in the left lateral decubitus position can help in the visualization of the radiological appendix. So because the radiological appendix is behind the cecum, and if you look it from the supine position, you won't be able to see it. So if you turn the patient, you put the patient in the left lateral decubitus, it will help you to visualize the radiological appendix. Another thing is posterior manual compression to the right lower quadrant in an anteromedial direction in conjunction with graded compression in the right anterior abdominal wall has shown to increase the visualization of the appendix. So what you do is you hold one hand with the probe, you compress, and you use the other hand to compress the back of the patient, as this image is demonstrating here. Last one there, okay. We look at the ultrasound features of normal appendix. Compressibility. The normal appendix is compressible. The wall thickness. The wall thickness is less than 3 millimeters. The diameter is less than 6 millimeters. We're talking of the diameter we measure from outside to outside wall. and the lumen should be empty or sometimes gas or fecal filled. And vascularity, there should be no evidence of hypervascularity. This is an ultrasound image of a normal appendix. So you measure from outside to outside. You see the calipers here, outside to outside, okay. We should aim to image the entire length of the appendix. This is where it becomes a problem, because sometimes you may only see only one part, but we have to try our best to show the whole length of the appendix. This is also a normal appendix. This is the transverse and the longitudinal. We should be able to see clearly the whole length of it. This is another normal appendix. Here, having the iliac vessels as a guide. So you try to find where the iliac vessels are and try to look anterior to it, find the appendix. This side is a normal appendix. You see the way it's appearing here, and you see the inflamed appendix, how it's so messy. The fig is so thickened. Laboratory markers. Laboratory results also help in determining appendicitis. So the measurement of C-reactive protein, CRP, is most likely to be elevated in appendicitis if symptoms have been present for more than 24 hours. Elevated CRP, elevated white blood cells, and neutrophils greater than 75% improve the sensitivity for diagnosis of acute appendicitis. So the likelihood in acute appendicitis would be lower in patients with normal values for all these three studies. So as you, as a sonographer, you're trying to scan patients, carrying appendicitis. You need to have an idea, how did they do the bloods? Or what were they finding for the bloods? Those gives you an idea that when you're scanning this with the laboratory finding, there's definitely, there should be appendicitis, or there's no appendicitis. There may be other causes of the pain. So we look at the ultrasound features of acute appendicitis. So in terms of the diameter, it's more than 6 millimeters. And then tenderness, there's maximum tenderness over thickened appendix. And there's the target sign. You see target sign, hyperechoic center of hyper and hyperechoic ring. Compressibility, it's not compressible. It's only compressible if it has perforated. Appendicular, echogenic focus with posterior acoustic shadowing. And vascularity, there's increased blood flow in the appendicular wall in early stages. So our job as sonographer, we find the appendix. We find the appendix, then we look at the appearance of appendix. We try to look at what's the diameter of this appendix. What's the maximum tenderness? How is it looking at? How is it compressible or not? How is the vascularity surrounding it? So this is an image of acute appendicitis with it's not compressible and diameter greater than 6 millimeters. If you put a color Doppler, you have shows increased vascularity in the appendicular wall. And this is another image of acute appendicitis. Increased, the distance is, the diameter is 9 millimeters, and you see the transverse, you see clearly the fluid surrounding it. And this is another image of acute appendicitis, and with completion and without completion. Without completion and with completion, it's not compressible. All the images look the same here, and the surrounding fluid as well. So images should be obtained in transverse and longitudinal, and both with and without compression. Perforated appendix. If the appendix is inflamed, sometimes if nothing happens, it may burst. So if it bursts, the patient comes to the hospital and then they send to you to have it the scan, to do the scan. You see if the appendix is perforated, you may see an abscess in the right lower quadrant pain, in the right lower quadrant. And in this case, this patient, you can see this, the first image here, this is only the part of the appendix, and you can see clearly here what's going on. This is using the linear probe. You change the probe to curvilinear low frequency. You see all this, it's all this correction here. Patient was having pain for more than 7 days. Sometimes you may not see a clear correction like this one. You may see appendicitis, but try to look outside it. You may see air outside the appendix. That you have to include it in your report because that's a sign of perforation. Another thing is the appendix might be tortuous. So if you look at the tortuous appendix, it's not straight. So one part it may be normal, but the other part is inflamed. So if you're not careful, if you only look at one part here and you say, oh, this is a normal appendix. If you didn't check properly the whole length of it, you may miss that this patient had appendicitis. Secondary signs. Secondary signs are reliable diagnostic tools and better facilitate clinical outcome and decrease the need for exposure to CT and unnecessary surgical procedures from negative appendectomies. So secondary features have high specificity and in predicting appendicitis when the appendix is not visualized. So you have tried your best, you can't see the appendix, then try to see, can you find any other clues that may give you that there may be some sign of appendicitis. We look at the ultrasound secondary features of acute appendicitis. Is there fluid surrounding where the appendix might be, around the base of the appendix, the base of the cecum? What about the local abscess formation? What about, is there any increased echogenicity of local mesenteric fat? You look for the thickening and echogenicity of overlying peritoneum. Is there any enlarged mesenteric lymph nodes? What about thickening of the fecal pole and adjacent small bowel? If you find all these things, you have to document it, because you may say, I didn't find the appendix, but I found this A, B, C, D. One other thing is this called lymphoid hyperplasia. This lymphoid hyperplasia has been associated with inflammatory conditions such as viral gastroenteritis and mesenteric adenitis. It is defined histologically as a cluster of more than 10 lymphoid nodules, all of which contain lymphoid follicles. So the lymphoid hyperplasia can change the compliance of the appendicular wall, making it non-compressible on ultrasound. That increases the diameter to greater than 6 millimeters, contributing to false positive for appendicitis findings. So the lymphoid follicles, if they enlarge inside the appendix there, and they make when you are compressing there, when you are doing your compression, the appendix is not compressible, and that if you only look at the size, the diameter, it's more than 6 millimeters. Acute appendicitis. You didn't check other things in other surrounding criteria. So lymphoid hyperplasia has ultrasound characteristics of producing thickening of the hyperechoic laminar profile. in the absence of 2 or more additional signs of appendicitis on ultrasound, e.g. periappendicular fluid, hyperechoic periappendicular fat, or mural hyperpremia, patient with appendicular thyroid hyperplasia and 6 to 8 millimeter maximum outer diameter have a low likelihood of appendicitis, and they therefore can be managed conservatively. So if you are scanning and then you look at the appendix is measuring more than 6 millimeter, can you try to check the surrounding? Is there any flow fluid? Is there any increased vascularity? If all those are normal, in most of the cases, there have been the cases that a lot of people find it difficult to differentiate between lymphoid hyperplasia and acute appendicitis because just saw the measurement is more than 6 millimeter acute appendicitis. When the patient go to theater, they take out the appendix. They take appendix, go to the lab, histology results says it was lymphoid hyperplasia, not acute appendicitis. Some limitations. Dilatation of the loop of bile in the right lower quadrant can obscure thickened appendix. The thickened appendix can be difficult to distinguish from the terminal ileum. The patient may not tolerate application of transducer to the painful area. The transducer may not have enough spatial resolution to visualize such small structure as a thickened appendix. So sometimes it's what kind of ultrasound scan machine are we using? The newer ones, they're better off compared to the old ones. Sometimes we may have two or three X-ray, the ultrasound machine in the department. There you use the other ultrasound scanner, which is a bit older than the other one. You may find it difficult to visualize the appendix. So that also plays some limitations in terms of what kind of equipment are we using to diagnose ultrasound to diagnose appendicitis using ultrasound. And this other thing of that the patient is feeling pain, reporting I feel pain here, but when you put the probe, you say, no, you feel more pain, you're hurting me. So that also makes limitation of the ultrasound. No, okay. Ultrasound report. When we are the surgeon, they send the patient to us to do the scan. For them, they are waiting for us to give them the answers. And our answers should be accurate and straightforward. So the report, you should indicate whether you have seen the appendix or not. The appendix is visualized measuring this, or the appendix is not visualized. So the report should have that statement that you have seen the appendix, you didn't see the appendix. Whether the appendix was normal or abnormal. And you should mention any secondary signs that have been demonstrated. And any other abnormalities that you have identified. If a patient comes, this patient is squarely appendicitis, it doesn't mean that that patient is ready for appendicitis. There may be, that patient might have a problem with if a female might be something in the ovaries, or there might be in the kidneys. So if you find any of those things, you have to include it in your report. Sometimes people, they have tendency of say, okay, I just have a quick look, there's nothing major, I didn't see the appendix, then say, no sonographic evidence of appendicitis. How can you say there's no sonographic evidence of appendicitis? You didn't tell them whether you saw the appendix or not, whether you saw any secondary signs or not. There's no mention of that. So the patient might come to you, they say, ultrasound abdominal pelvis, query appendicitis. You have scanned the abdomen and the pelvis, and then you you try to describe about the liver, you have described about the liver, the kidneys, and then in terms of appendicitis, you just say no sonographic evidence of appendicitis. That's wrong. How can you say no sonographic evidence of appendicitis if you haven't seen the appendix? You need to give them the answer, the referral. Did you see the appendix or not? If you saw the appendix, was it normal or not? Were there any secondary signs? Were there any fluid? How was the echogenicity around it? Were there any collection? All those things we need to provide them. So when the patient goes back to the referral may look at your report, and with the signs and symptoms of the patient, they make a correct decision. Improving diagnostic performance. We all know how to do ultrasound. We all know how to scan the appendicitis, but we don't practice much as often as we are supposed to be. So in that case, we lose our skill to identify the appendix. I've seen most of people say, it's difficult. Let's just send patient for CT. You send patient for CT, you're going to say to give radiation dose to the patient, high radiation dose. You didn't try it. Send patient for MRI. Not every hospital has MRI. It just be all those things you have to take into consideration. Ultrasound is cheap, readily available. So sonographers' additional training in scanning technique and awareness of cellular science significantly improves the rate of visualization and provide referral with more meaningful findings. So the referral, they need meaningful findings, not just a vague report. Involvement by experienced personnel, adequate time to perform the study improves the ability to visualize the appendix, hence help in patient care and hospital resources. If you take your time to find the appendix, sometimes you may see the appendix, you only see part of it. You can't see the other part. If you have your colleague, call your colleague. Let's have a second look. In so doing, you're improving yourself as well, and you are also helping the patient, because if you take your time looking for appendix, you see the appendix, whether it's normal or abnormal, it ends there. If you didn't see the appendix, that patient might goes back to the clinician, the referral, look at your report and diagnostic, and then they try to send that patient to CT or to MRI. That's increasing the more hospital resources. Lastly, let's think about auditing. Suppose, let's take a duration of time. How many patients have you done? Think of how many patients have you done looking for appendicitis, that they had clinical suspicion of acute appendicitis, and they came to you to do the scan. Out of those patients, how many patients were you able to identify the appendix? And how many were you not able to identify the patient? If we try to think in that category, that will make us to improve. For those patients that you saw, this patient, I identified the appendix, and the appendix was normal, or there was appendicitis. Out of those patients, let's suppose you had 20 patients, you said they had appendicitis. Out of those patients that you said they had appendicitis, how many were true positive and how many were false positive? How do you know that? That if you said that patient had appendicitis, they took that patient to theater. If they take out the appendix, they send to lab for histology, and then when they look in the lab, they will either tell you that patient had a positive appendicitis or not. So it's good to have a good working relationship with the referrals, the surgeons, because if they take out the appendix, they may they send it to the lab, and then the results of the lab, you try to compare with what findings you had. If sometimes you may say, I didn't see the appendix, but out of those patients that you say you didn't see the appendix, if you do the follow-up, how many did they end up having appendicitis? How many patients did they send up to other modalities like CT and MRI, and they find that this patient has appendicitis? You in your report, you just looked at, say no evidence of appendicitis identified. And then the patient will end up going for CT or MRI, and then this acute appendicitis. So if we try to follow up that, by the end, we are improving ourselves as well as helping the patients. I think I've talked much for now. What can we do? We have to keep practicing and have more confidence. Thank you for your attention.
Thank you so much, Mr. Mwase, for this presentation. It was very informative and very educative. I would like to, let me be the first one to contribute. Appendicitis, especially when it comes to sonography, just like the way you have indicated, it's somehow difficult, but with practice, with more practice, you can easily pick up one or two things. Let me mention to say, with literature, the hallmarks of appendicitis sonographically, if you look at the size is supposed to be less than 6 millimeters. However, sometimes when you are dealing with patients who are obese, you agree with me that some patients who are obese, sometimes they might have a small appendix, and those who are slim, they will have a big appendix, especially when it comes to diameter. So sometimes you find that it's bigger than 6 in slim patients, but it's less than 6 millimeters in big patients. So what is the take-home message here is the hallmarks or the vanguard of appendicitis. One is to look at the luminal thickness. Is it more than 3 millimeters? Then, just like you mentioned, look for the surrounding. Is there adjacent echogenic fat? Whenever there's appendicitis, you will see that there's increased adjacent echogenic fat. Then after that, of course, it has to be coupled with the laboratory results, just like the way you indicated. So I just wanted to make mention of those few things. So thank you so much for that presentation. At this point, I think we can allow some questions, contributions, or deliberations. Thank you.
Through the chair.
Yes, Dr. Banga, please.
Thank you. Thank you very much, Gabriel. We really appreciate. I've learned a lot of things, especially that the last time that I did the ultrasound was in Botswana, almost more than 16, 17 years ago. And for those who doesn't know Gabriel Mwase is a Malawian radiographer based in Ireland. And this is the second presentation that he has given us under the Radiological Society of Zambia. Thank you very much, Gabriel. You are
welcome.
You are contributing to the development of radiography, not only in Zambia, in other countries as well, like Malawi, Zimbabwe, and Botswana. Now, the only thing that I've liked it, at the end, you have included a very important part on clinical auditing, because this is where we are poor, you know, or this is where our weakness is in our countries, especially Zambia and Botswana, where I've worked. It's very important to do clinical auditing, because you are comparing your findings or your skills to the lab and surgery. These will improve your practice, you know, because once you see the results from the lab or or from the surgery, you are going to ask yourself, why did I miss this? You know, and that one will improve your practice. It will assist you to study more. Thank you very much. That is my contribution.
Thank
Thank
you.
you very much, Dr. Wanga. Actually,
May
if
I
we
know
look-
how is your protocol there in terms of appendicitis down there? Are you able to have conversation with the surgeons, or how does it work in Zambia?
I think I can speak on behalf of Zambia. The protocols are such that, of course, once you do a scan, you can make a follow-up with the surgeon. Just like the previous speaker said, Dr. Wanga, audit is part of quality improvement. It's actually one of the pillars of clinical governance. As we all know that clinical governance, this is a backbone of quality improvement in every field, be it radiography, pharmacy, or what. So yes, a protocol allows us to make follow-ups. Once you do a scan, then you can make a follow-up. Thank you.
Okay. Any more contributions? Or you can tell us what you do in
It's
your
open
practice.
it's open for questions, contributions. People can kindly raise their hands, then they can make contributions. Someone is asking if we can share this presentation. Of course we will.
Yeah, we should share it.
Yes, hello. Good evening. You can hear me?
Yes.
Yes, I'm Muhanji Mika. I'm from Uganda. Maybe I just wanted to add something about technique.
Yeah.
I don't know. I came in a little bit late. I don't know if they talked about it. It's something which I've noticed sonographers usually don't do, or some people don't do whenever they are looking for the appendix. When increasing the sensitivity of detection of the appendicitis, your appendicitis pain is usually focal. It's in one place. It can be also in the left iliac fossa. However, 99% of cases will be in the right iliac fossa, but the pain is most of the times focal. It's in one place. So you ask the patient to point with the finger where the pain is. Don't allow them to give you like a vague area and the whole iliac fossa. No. Tell them, where is it? Is it in one place? Is it all over the whole region? Because most of the times, if a person has appendicitis, it's going to be in one place, and you point with a finger to that place. So you just put a probe and search in that place. The other part, the second maybe point we can also do to increase the sensitivity is if they maybe tell you that, for example, the pain is in the right iliac fossa and it's all over, try using graded compression technique. Keep pressing as you're looking at this patient, as you're looking at your screen. Whenever you press and you see that the patient reacts to the pain, then most likely that is where the appendix is. Because the pathology of the appendix is usually to cause pain in one place. So if you keep pressing in that iliac fossa and the person does not react, does not give any facial expression of pain, then you know here we are safe. So you keep pressing until that one place or one point you press and the patient guards the abdomen. But you do it slowly and in a professional way so that the patient cannot know, because this is, remember, your technique. So I think with those 2 points, someone can easily find the appendix, because once you keep in that area, you usually find the appendix, and I've found it at least 100% of the cases I've tried to do that. And then for the protocol in Uganda, for us, we use 6.5 millimeters. So if a person is below that, then no appendicitis. If a person is above that, then we take it that there's appendicitis. And also we can also follow up with the surgeons and get to know that what happened after the surgery. And usually it's good. And just for clinical knowledge, and also as they have said, the confidence. Ultrasound is more of confidence, that when you're confident you can do something and you can sit in, you diagnose almost what the disease is. But if you're not confident, even obvious things will scare you to make a diagnosis about them. Otherwise, thank you very much to the presenter from Ireland for the wonderful presentation. Thank you very much.
Thank you.
Thank you, Mr. Mika, for that presentation, for that contribution. Any other contributions, questions? It seems like we don't have we don't have any questions or contributions. This simply means the presentation was on point. So thank you so much, Mr. Mwase.
Thank you. Okay.
We'll surely call upon you again.
Okay. Thank you all for attending, and let's just have confidence in practicing and doing our best to help the patients. That's the main goal. Thank you.